www.catheterization.com. Today I'm going to present my original research, exercise hemodynamics among patients with dyspnea on exertion, also called exercise-induced pulmonary hypertension. This research was done in conjunction with Dr. Rumbach and was done at a facility with a large outpatient private practice. We have a pulmonary hypertension registry in our practice where we included patients with high pulmonary artery pressures. Pulmonary arteries take blood from the heart to the lungs. We included patients who had a high pressure on the right side called RVSP on echocardiogram. Patients with symptoms of dyspnea, effort intolerance, and exertion fatigue were thus included. In our cath lab, all patients had a 6 or 7 French tube put into the veins. We used minimal sedation and we obtained pressure measurements at baseline, after which a 2.5 pound weight was attached to the patient's wrist and the patient did arm movements similar to jumping jacks for 3 minutes. We had a total of 172 patients in this presentation. Pulmonary artery pressure was measured. Pulmonary arterial hypertension is classified as WHO Group 1, WHO Group 2, exercise-induced, normal, or exercise not done. WHO Group 1 patients numbered 24. These are patients who had a high PA pressure and a high wedge pressure. WHO Group 2 patients were 37 and they had a high PA and a high wedge pressure. Exercise-induced pulmonary hypertension patients had normal pressures at rest. With exercise, the mean pulmonary artery pressure went above 25. Patients who were normal were 54 in number and their PA pressures were normal at rest and did not go up with exercise. We had 30 patients who did not do exercise and thus we don't know what happens to the pressures with exercise. A third of those patients with a resting PA pressure less than 25 showed an elevation with exercise. The resting LV ejection fraction was similar across the board. Gender, hypertension, smoking status, dyslipidemia, and body mass index were similar amongst the groups. The groups differed with regard to age, with exercise-induced pulmonary hypertension patients being significantly older. This slide presents the output of the multivariate regression and shows that the age alone is significantly different between patients with exercise-induced pulmonary hypertension and those without. The VO2 max, which is a measure of overall fitness and is a single number that represents how well the body extracts oxygen with exercise, was available on 32 patients. In the patients who had exercise-induced pulmonary hypertension compared to Group 1 and Group 2 patients, the VO2 max numbers were similar. This implies that these patients were just as sick as those with WHO Group 1 or Group 2 pulmonary hypertension. The VO2 max in comparison to those patients with a normal exercise response was much lower in patients who had exercise-induced pulmonary hypertension, indicating that the patients with exercise-induced pulmonary hypertension were sicker. When the Wassermann curve was examined, a clear-cut flattening of the stroke volume, as indicated by the blue line on this curve, was noted in several patients. This is similar to the finding noted in patients with pulmonary hypertension. When patients were given long-acting nitrates, there was a favorable response with 80% of patients who had exercise-induced pulmonary hypertension responding favorably to long-acting nitrates with regards to symptoms. 3 distinct CPET patterns were noted, and pattern 1 is displayed here. That shows a flat stroke volume curve and a normal heart rate response curve, which is in red. The second pattern shown in this slide shows a chronotropic incompetence pattern where there's no increase in heart rate with exercise. The heart rate line is a red line, stroke volume line is a blue line. And the third pattern is a combined pattern where there's a flattening of both the heart rate and the stroke volume curve. In conclusion, patients who present with shortness of breath and elevated RVSP on echocardiogram are quite restricted based on their VO2 max. Their investigation, with the exception of exercise-induced right heart cath, is benign. Thus, all patients who present with these findings should undergo exercise-induced right heart catheterization. 3 distinct CPET patterns are noted. These patients have a favorable response to long-acting nitrates. Using a beta blocker in those patients in whom cardiac output is dependent on a heart rate may worsen the symptoms. CPET provides an insight into this, as the patients are heart rate dependent to increase cardiac output and they have chronotropic incompetence. We speculate that the underlying pathophysiology of this condition could be microvascular angina or HFpEF, heart failure preserved ejection fraction. Further research into this important condition is warranted. Thank you very much again for watching this video. Thank you for visiting my website, www.drabbasali.com.